Today I shall be your facilitator. My name is Dr. Kandiwo, and we'll have our didactic presenter, who is Dr. Mweemba, a consultant physician, nephrologist by specialty. Before we go into details, I would just like to recognize those that have joined in today. I will mention a few facilities. I can see St. Francis Hospital is with us. We have Mukuni Health Center from Kazungula, welcome. We also have Levi Mwanawasa, UTH joining in. We have Lundazi Urban, Matero. I can see Kaoma District Hospital has also joined in today. And we have a number of individuals that have joined in today. I can see there's Morgan, David, that's Mr. Nyirongo there. So I'd just like to welcome you all. If you can hear me, maybe you could just kindly wave. Thank you very much. So before we go into today's topic, I will ask Dr. Foloshi to give us a recap regarding what we discussed last week. So Dr. Foloshi.
Thank you very much, Dr. Kandiwo. So last week, we had Professor Lloyd Mlenga discussing contraception and women of childbearing potential and ART. So we discussed things such as what are the clinical goals for women with HIV preconception before they actually even get pregnant. So we need to plan that we prevent unintended pregnancies in these women. We want to prevent HIV transmission to partners. We want to optimize the patient's health, of course. We want to improve pregnancy outcomes, and we want to prevent perinatal HIV transmission. So reproductive options for women with HIV, the discussion should be ongoing. So something interesting came up. What if a woman of childbearing potential wants to be on TLD? We learned that DTG, dolutegravir, should be offered to all women, even those with childbearing potential. This is an option that should be offered for them because we know that DTG is one of the best ARVs on the market. But also, we need to inform these women that the effects of DTG on the unborn child, they are still being evaluated. So they should be offered DTG with full information and contraception, but they should still be offered even if they choose not to be on contraception. We need to remember that the discussion is ongoing. So family planning is optional and is not a requirement for women to access ART.
Thank you very much for that recap, Dr. Foloshi. We'll go into today's topic. As I mentioned earlier, we'll be looking at HIV in the aging population. So in the hub, we have a few subject matter experts that are going to help us discuss the case as well. From the Adult and Pediatric Center of Excellencies, that's Dr. Mpeta, Dr. Thomas, and a few other people. So let me introduce Dr. Mweemba, who will be our didactic presenter today, and we'll go straight into the presentation. So Dr. Mweemba.
So thank you so much, Dr. Kandiwo. Next slide, please. So I think our learning objectives include the current evidence of impact of CRT on life expectancy in people living with HIV, selecting CAT regimen in older patients with different comorbidities, preventive care considerations for health order patients with HIV. So first of all, I'll go to the poll questions. So poll question number 1, life expectancy in HIV patients on CRT is equal to the general population. It's either a true and false. Next.
So we have the first poll question. We'll just give people a chance to kind of pick the right answer, or the answer they think is right, and then we'll discuss the questions at the end. So our first question reads, life expectancy in HIV patients on combination ART is equal to the general population. So we can vote if we think that's a true statement or it's a false statement. So what do we think about life expectancy? Those that are on ART. Okay, I'll just relaunch the poll just to give people a chance to poll. Do we think life expectancy is the same? Hmm? Okay, so we have at least 70% and above thinking it's true. We give it a few more seconds. Okay, I'm going to end the poll now. We'll share the results and discuss later. So we have a second poll question, and the second poll question is, TDF, 3TC, and DTG is not contraindicated in an older patient with cardiovascular disease. So do we think this is true, or do we think it's false? Okay, so that's our second question. TDF, 3TC, DTG, or what we call TLD, is not contraindicated in older patients with cardiovascular disease. Do we think it's true, or this statement is false? So we can poll. The majority think it's true. You can also compare our answer.
Yeah. So it's okay now. Okay.
What about that Zoom meeting webcam? It's not
No,
it's
May I remind the participants to kindly mute your microphones? Thank you. Okay, I'll end the poll now. So we have a third poll question, and the question reads, TAF, FTC, and DTG is not approved in older patients with an eGFR of less than 30 mils per minute. So TAF, FTC, and DTG is not approved in older patients with eGFR of less than 30 mils per minute. So we can vote. Which answer do we think is true? So we can vote if we think it's true, or if the answer is false. Okay, so the votes are split, 67-33%. What do we think about TAF in older patients with an eGFR less than 30? I'll give it a few more seconds. We want to know your views regarding the use of TAF in relation to eGFR. That's the estimated glomerular filtration rate. Okay, I'm going to end the poll for this question. Then we have our final question. Okay. And the question reads, combination antiretroviral therapy reduces cardiovascular disease in the earlier stages of treatment, but the risk of cardiovascular disease increases in later years. What do we think about this statement? Do we think this statement is true, or do we think it's false? Okay, the majority think it's false so far. Okay, it's almost split 50-50. So what do we think about combination ART and cardiovascular disease? As someone, over the years, and someone who's already on ART, do we think the risk increases? Does it remain the same? Does it reduce? Okay, so we have 30 out of 56 who have voted. I'd love to see all the facilities vote. Okay. It's interesting. The response is almost 50-50%. Okay. All right, I'll end the poll now and we'll discuss the answers later. So we'll allow Dr. Mweemba to continue with the presentation.
So thank you so much, and I hope that by the end of this presentation, I'll shift some people. That would be my, I'll be marked by that as well. So this is from the social scientist's perspective, and I got this from a lady called Ida Mukuka. Probably some of us know her. She's in social sciences and has been very supportive of our program in the country. And she says that older people have been forgotten in the HIV/AIDS agenda. And she goes on to say that we know that 1.4 million orphans in Zambia, and many of these actually stay with grandmothers. And when their mothers die, the blame usually is on the grandmothers, as they are labeled as bad teachers, and some get divorced because of their daughters or sons dying. Grandmothers were isolated, discriminated, and stigmatized, some of them with self-stigma when they lost their children due to HIV. And HIV positive order, people failed to come out as it was believed to be disease for the young. So there's still stigma that goes on with people that have HIV and are much older. How do I change? Next. So this slide, let me change it. Take it back. Okay. So this slide, how do I point? Okay, so I can just move it like this. Okay. So this slide is just trying to show you that this is from the Netherlands, following up 10,270 HIV-infected individuals. And you can see that in 2010, 28% of them were aged above 50 years of age. This is projected that this age is going to increase by 2030 to 73%. Next. Next. This is a Zambia study, and you can see that the proportion that is above 40 years in our population is actually also increasing. And so we are not only talking about Netherlands here, we are also back home here. Next. And this slide shows you the numbers in terms of percentages of individuals that were in the Zambia study again, above 55 per province. And you can see that this was just a sample, and you can see that the proportions are quite high. And therefore, what we are saying is that individuals who are older than 55 years, even in our population, is getting bigger. Next. This is just a study which tried to look at between 1996 and 1997 up to 2011. You can see that the blues, the dots here just tell you the life expectancy at 20 years old of age. And you can see that from 1996 up to 2011 is that for those who are HIV negative, those in blue, the age expectancy has remained the same. But when you look at the HIV individuals, that expectancy in life has greatly increased, but it has not yet caught up with the people who are HIV negative. And when you look at mortality, the line here just shows you mortality. That in the general population, the dotted line, mortality has remained almost the same. But in HIV individuals, that mortality has dramatically come down. But we still have a small gap that has remained that HIV individuals have not yet caught up with. Next. This is the same, almost the same data, although this is from Denmark. And again, you can see that the probability of an individual who was HIV positive in 1996 was very low. It improved in 2000 to 2005 and got better between 2006 to 2014. But again, this has not yet caught up with the people that are HIV negative. Next. 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 So this slide just shows you that we still have a gap between HIV positives and HIV negatives. People who are HIV positive are more likely to die earlier than people who are HIV negative. And we know that an individual who's HIV positive and is at 50 years old, they probably look like they are at 70 years old. So there's like accelerated aging in HIV individuals. Or we do not know that maybe actually this is just an increased risk. Next. And so to address the gap between the HIV positives and HIV negatives, that there are so many factors that we need to close up. The virus itself, so we treat these individuals, but starting treatment very early is very important. But there are other factors that we usually don't, you and me, when we're seated in that clinic, we do not follow. And these are the factors that we need to discuss today. Next. So fixing the gap requires that we address these factors. So we need to gap up that area between the HIV positive and HIV negatives. Next. And so this slide tries to show you some of the risk factors for HIV individuals, and one of them is cardiovascular risk in HIV individuals. And we know that it's U-shaped, and I think that this was one of the questions. So you can see that when you start ART, there's dramatic reduction in terms of mortality in people who are on ART. But again, this tends to start increasing slowly until it gets very high when people have been on treatment for a long period of time. And this is usually because of traditional risk factors, which we always miss. It could be because of inflammation or some of the drugs actually that we give them. Next. So in New York City, between 201 to 212, you can see that mortality in the cardiovascular mortality increase in HIV individuals from 6% to 15%, way above the general population. Next. And this is a study, and you can see that adverse events are higher in HIV patients with a delayed treatment and older patients. So you can see that this arm here shows you early treatment, or that is early treatment. And you can see that when you start treatment early, the mortality is far much reduced. When you delay treatment, people die. And that's what that shows. But look at the older group. So these older individuals, that if you start treatment late, the consequences are even higher. And so we need to be starting treatment early. Next. This is just trying to show you some of the NCDs that are common in HIV individuals. Is it this orange? The orange shows you HIV negative, and the gray shows you HIV positive. You can see that across the board, myocardial infarction is higher in HIV individuals. Kidney disease is higher in HIV individuals. And this tends to increase as you get older. So the younger, better. But as you get older, the risk increases. Same applies to non-AIDS defining cancers and the AIDS defining cancers. HIV is a risk for all this. Next. Okay, this is just coming back to Zambia. And you can see that in Zambia, the proportion of patients with impaired fasting blood sugar in copper belt was about 15%. And this is usually we miss. And this is the gap that we are discussing, that the gap between the HIV and the non-HIV is because we are not looking for these other issues. Next. This was a poster presentation, AIDS 2018, which was just last year. And what it shows is that of all these patients that were screened, 13.6% had at one time had an elevation in blood pressure. And only 29% had at least 2 BP's measurements over millions of visits. And so what it tells us is that we are actually missing a lot of these hypertensions. And these are the things that are killing our AIDS people. Next. Okay. Then I come to another common thing, which is fracture prevalence in older HIV individuals. You can see that this is HIV positive and this is HIV negative. So fractures are higher in women that are HIV positive. In men, you can see that those who are negative, actually, it seems the fracture risk gets down. But in HIV, it increases. So HIV predisposes to fracture risk. Next. Fracture prevalence, particularly when you use TDF or PIs, again, is very high. I'm just trying to mention this because all the patients are prone to fractures. So when you use TDF and PIs, it's very high. You can see here when TDF was compared to ABC, you can see in the spine how much TDF caused bone mineral density reduction. And same applies in the hip. This one just trying to show you efavirenz versus atazanava, and atazanava here was a risk factor for reduction in bone mineral density. Next. TAF on the other side seems to be better. So in naive patients, when you give TAF versus TDF, is that the reduction in bone mineral density is less in the spine. And it's also less in the hip. And when we switch patients to TAF or on TDF, you can see that on TDF, the mineral density remains almost the same, but in TAF, it actually improves. It gets better. So for those older patients that you think that have a bone risk fracture, is that TAF, which is coming in our system, is probably the best drug to give. Next. This is cumulative exposure to ARVs and associated with kidney disease risk. You can see that all the medications that are listed here, TDF, atazanava, lopinava, ritonava, plus other PIs versus the ABC. When you look at the risk, depending on the number of years, that the risk is higher, whichever drug that you give for kidney disease. The ones you see down here, HIV negatives, and they are lower than the counterparts receiving all these drugs. When you replace TAF in CKD, you can see at all levels of kidney disease, actually TAF does well. The GFR remains constant all over. Below 30, it remains constant. Next. So things to think about before starting ART in older patients. ART recommended for all patients regardless of CD4 count, especially important for older patients, because they have a greater risk of serious non-AIDS complications, which I've just illustrated. Potentially, they have a blunted immunological response to ART, and therefore, we need to start them early. They have adverse drug events from ART, and concomitant drug may occur more frequently in other patients. So we need to remember this, that their reactions to drugs are different from the general population. So this can lead to bone, kidney, metabolic, cardiovascular disease, and liver disease, and so this should be monitored closely. We need to remember, as we are going to see some of the cases that have been posted, that polypharmacy is very common in older patients. And this is something that you need to sit and probably consult with a lot of people around to just see that there's no risk for drug-drug interactions. Next. So these are some of the recommendations. So for a CKD patient who has less than 50 mL per minute, consider avoiding TDF. And the agent you can consider in our setting is either TAF, ED, or in combination with efavirenz. Or you can use ABC regimen with DTG and efavirenz. Just remember that for TAF, the eGFR should be above 30 mL per minute. You cannot give it below 30 mL per minute. Remember also that 3TC requires dose adjustments, especially if your kidney function is less than 50 mL per minute. For patients that you think have a risk of bone disease or osteoporosis, again, TDF should be avoided. And TAF or ABC should be the replacement. Greater bone marrow loss with PIs as well. Remember that your PIs are more likely to increase your bone mineral density loss, and TDF. Cardiovascular risk, not much evidence, but ABC should be avoided. And TAF and TDF should be considered. If choosing based on a boosted PI, atazanava may be preferred as compared to darunava or lopinava. Hyperlipidemias, remember that the PIs, when they are boosted, they can increase the risk. And the best would be, again, TLD. And we know that TDF was associated with lower lipid levels versus ABC or TAF. So when you have lipid issues, TDF probably is the best. Next. So keeping health, HIV individuals' health, how to beat inflammation and limit comorbidities. Adhere to HIV medications. Quit smoking. If you're obese, you need probably to reduce your calorie intake per day. Exercise. Reduce alcohol intake and avoid drugs. Provide vaccinations for those that need vaccinations. And cancer screening is also very important. And I've listed some of the cancers here that need to be screened in our population. Next.
Okay. So thank you very much, Dr. Mweemba, for that wonderful presentation. I think we have been enlightened on some of the challenges that elderly patients living with HIV tend to face. They're at risk of most of the comorbid conditions, and in treating the comorbid conditions, we give a lot of drugs. So imagine the pill burden. There's also a risk of drug-drug interactions. So we need to screen the elderly patients living with HIV in our care for all these other comorbid conditions. So we've discussed most of the poll questions. So I'm just going to relaunch the poll to try and find out if we've grasped one or two things from the presentation. So I'll start with the first one, which I think Dr. Mweemba explained very well in one of the graphs just at the beginning of the presentation. And this was on life expectancy. So what do we think now after the presentation regarding life expectancy in HIV patients who are on combination ART? Is it equal to the general population? So I'm going to relaunch the poll. And then we'll discuss the questions. Okay, so give us 1 or 2 minutes to vote. After this presentation, what do we think regarding life expectancy in patients who are on combination ART versus the general population? Is it equal? Okay, so we have 35 facilities who have voted so far, and the majority think it's false. Give it a couple of seconds. Let's continue voting. What do we think? Does life expectancy change and equate to those who are not living with HIV? If someone is on ART? Okay, we have at least 66% of the participants who voted so far. Okay, I'm going to end the poll and then we can discuss the results with Dr. Mweemba. So this is how we polled. 73% think it's false and 27% think it's true. Dr. Mweemba, what's your comment on that?
So at least we have changed some people's minds. That's true that life expectancy is not the same. The gap has been closed, but we still have that small gap that we need to close up, caused by those comorbidities that I've mentioned. Not the treatment, but the comorbidities, and we need to look for them.
Okay, thank you very much, Dr. Mweemba. So we'll go on to the second poll question. I am going to relaunch the second poll question. And the question reads, TDF3TC-DTG, which is our TLD, is not contraindicated in an older patient with cardiovascular disease. The TDF3TC-DTG is not contraindicated in an older patient with cardiovascular disease. Okay. That's the second question. So what do we think regarding the use of TLD in older patients with cardiovascular disease? I'll give it seconds. Okay, we had 46 facilities, 47 now that have voted. Okay. So this is how we voted. Dr. Mweemba, would you like to comment on the results?
Well, I'm happy about the results because 84% think that TDF is not contraindicated in older patients, which is true. It's not contraindicated. ABC is contraindicated and not TDF.
Okay, thank you very much. We'll move on to the third question. And the third question is TAF. I think Dr. Mweemba was just talking about TAF and telling us the benefits of TAF a few minutes ago. So TAF, emtricitabine and DTG is not approved in older patients with an eGFR over less than 30 mL per minute. What do we think? So I will relaunch the poll and we can vote. Do we think this statement is true or do we think it's false? Okay, so far the majority think it's true. I think Dr. Mweemba spent some time telling us about the eGFR, when you can use TAF, when you can use TDF. So what do we think? Can we use it in patients with an eGFR of less than 30 mL per minute? Okay, I'll just end the poll and allow Dr. Mweemba to comment on the results.
So the majority think like me. Yes, under eGFR less than 30 is that the drug is currently not approved, especially that it comes as a combination drug. Remember that FTC has to be adjusted below that level, and we are hoping that probably in future we might use it.
Thank you very much, Dr. Mweemba. We are going to launch the last poll question. And the question reads, combination ART reduces cardiovascular disease in the earlier stages of treatment, but the risk of cardiovascular disease increases in the later years. What do we think about this? Is it true or is it a false statement? I'm so happy with the results. Looks like we have a unanimous vote. Okay, and what do we think? Long-term risk. So we have 92% think it's true, and only 10% think it's false. So we have results from 47 facilities, or 47 participants out of the 70 we have, so we can vote. We'll give it a couple of seconds. Do we think the long-term risk increases? Okay. So I'm going to end the poll and share the results. So 90% think it's true. The risk increases in the later years.
That's true, and we need to think about that as we treat these individuals, they get older. As they get older, is that they have cardiovascular risk, they have cancer risks, they have metabolic risks that we need to look for so that they don't die, and we need to attend to those. Thank you.
Thank you very much, Dr. Mweemba. Go through a summary.
Yeah. So summary, older HIV population is increasing, and thanks to CRT, older age is associated with non-communicable diseases with increased burden of medications, and so anticipate more adverse events and drug-drug interactions. Select a regimen that will be well tolerated and not aggravate underlying conditions or increase cardiovascular risk, chronic kidney disease, or fracture risk, including cancer risk. Thank you.
So thank you very much. That's the end of our didactic presentation. At this point, I will invite a few comments or questions from the network. Do we have any comments or questions regarding the presentation and what has been discussed so far? In the meantime, I would ask Lucy and the team to get ready to share your case. Lucy from Lewanika. Okay. So do we have any comments, questions before we go into the case discussion, the case presentation and discussion?
There's a comment in the chat.
Okay.
There's a comment in the chat.
All right.
Patrick.
Okay, so we have a comment from Patrick. And Patrick says there is a great need to emphasize the need of screening our patients on ART for NCDs and to effectively manage them as they have an impact on the prognosis. This is always overlooked. I like your comment, Patrick, because I think Dr. Mweemba actually emphasized on that. I think he highlighted how often these patients actually checked for things like hypertension, and it's really important that we screen them even as they come to see us, not just for how they are doing on ART, but also for these NCDs. Remember, they're elderly patients, so they're at higher risk of developing these comorbid conditions that we also need to look out for. The other things that he mentioned, obviously, the kidney disease and the malignancies as well, and these are more common in the elderly patients. Do we have any quick comments before we go to the case? Lucy, in the meantime, are you able to hear us? Lucy and your team? Lucy, kindly unmute your microphone. We just want to know if you can hear us from the hub. Okay, you can read the question. I can't see. Okay, we have a question or comment from Saidi. So Saidi, you can go ahead. Said Nuren, you can go ahead with your question or comment. Okay, we are unable to get through to Saidi. So do we have any other question, comments? Okay, I think we'll go into the case presentation. So, Lucy, you can go ahead with the presentation. Lucy and Lukonga, are you able to hear us? Okay, looks like they're unable to hear us.
We are able to hear you.
Oh, all right, great.
Can you hear us?
Yes, we can.
Okay, good afternoon, everyone. My name is Lucy Samba, under the Mulunga District, Nurse Mentor, presenting a case from the Mulunga State 2. I'll start with the history. 2024, a widow tested HIV positive in 2005 and has been on ART since then. The husband died in 1999 due to stroke. Our most recent visit was on the 3rd of April 2019. Adherence is good and does not miss appointments. Can you hear me?
Yes, we can.
Okay.
Yes, we can.
Adherence is good and does not miss appointments. No history of diabetes, hypertension, kidney disease, or fractures. She had 11 children, but only 5 are alive. The 6 died of HIV-related chronic illnesses. She stays with 8 grandchildren, 3 of whom are in school. The rest do piecework to earn their living. She then remarried in 1999, but later the second husband died also in 2001. Physical examination as the last visit. On general examination, January physically well and stable. Her height is 156 centimeters, weight 70 kg. Her BP is within normal range, 128/70, pulse 86, temperature, though not there, but it was normal. When we recorded it was 36.2. Chest, clear breath sounds, CVS, normal heart sounds. Clinical timeline and lab results. I only present the results which are available. ART regime that goes up to date. She was on AZT, 3TC, MVP on 05, which started on 5th of April 2005. And then later she was switched to TLE on the 30th of January 2014. She was tested HIV positive on 24th March 2005, and then she received her result as HIV positive on the same day. Available viral load results as from 23rd February 2016. Results were 4,139 copies. Again, they repeated the viral load on 22nd January 2018, and the results were 96,263. Thereafter, they did another viral load test after enhanced adherence counseling on 23rd August 2018. And then the results came as not detected. This time she was engaged in an enhanced adherence counseling. Then available results for CD4, those were results just from 2016. From the time she started, we didn't see the results. But these were viable results as from 17th August 2016. The results were 634. And then they repeated another viral load on 10th July, CD4, 10th July 2017. The results were 839. Thereafter, they did another viral load CD4 test on 22nd January 2018, and the results were 614. RPR couldn't trace any results, but for creatinine, it was done on the 22nd January 2018. Results were 84.1. Then ALT, which was done on the same day, it was 13.8. And then the hemoglobin AST, 34.2. The hemoglobin was 11.2. So we have the following questions. Can we maintain on the same regime or we switch out to TLD? 2, what measures are put in place for the care of the elderly patient living with HIV? Then the third one, are there any plans to include them in the national guidelines?
Thank you very much for the presentation, Lucy. So I'll just try and summarize the case so that everyone's on the same page. So we have a 76-year-old female who has been on ART since 2005. Her initial regimen was AZT, 3TC, and MVP from 5th April 2005 until 2014 January when she was switched to TLE. And she's a widow, has had 2 husbands. Of note, currently she has a viral load which is undetectable. Prior to that, she had 2 viral loads which were very high. One was 4,139, that was in 2016 February, and another one done in January 2018, which was 96,263 copies per mil. And I think at some point they actually engaged this patient in enhanced adherence counseling. So as we speak now, the viral load is undetectable, and this was done on the 23rd of August 2018. So Lucy and the team have got 3 questions, and the first one is they want to know if she should be kept on the same regimen or she's actually a candidate who can be transitioned to TLD. So do we have any questions from the participants or spokes, any clarifications, contributions towards Lucy's case? Senanga, do you have any contribution? I can see Monza Mission. Monza Mission, would you like to contribute towards the case? Do you have any questions, clarifications? Okay. So Nangogwe has raised their hand. Nangogwe, you can go ahead with your question. Nangogwe.
Good afternoon.
Good afternoon.
Yeah, I would like to know how important it is for this client to have, for the clinician to have calculated the creatinine clearance, other than just looking at the creatinine only.
Okay, thank you very much. So we have a question. They want to know which one would be more important, using the absolute creatinine value or the creatinine clearance for the patient. Lucy and the team have given us all the parameters. Lucy, do you have an estimated creatinine clearance for the patient? To respond. Okay, just to help out Lucy and the team, so the creatinine clearance is calculated at 67 mils per minute. So it's above 50. Nangogwe, have we answered your question? Yes. So I think to follow up on what Nangogwe had asked, so what we often use is the creatinine clearance and not the absolute creatinine value, because that can, it's a wide range. It depends on a number of factors, including the weight, the sex of the individual, and so on and so forth. So Yeta District Hospital, you have a question. You've raised your hand. You can go ahead with your question or contribution.
Good afternoon. Thank you, Madam Lucy, for that presentation. I find it interesting that the client has 2 high viral loads, one in 2016 and one in 2018, and both times she was on TLE. Did we find out what exactly was causing that from the ESTs that we conducted so far? What exactly were the contributing factors to these high viral loads? Was the patient really adherent? Was she using condoms? What did they identify as the cause of the high viral load? Because to come from 6,000 to not detected, as much as it took quite a lot of time for the results to be obtained at the facility, I noted the high turnaround time as well. So I'd like to know what the contributing factors were to those 2 high viral loads that were noted, and if there's any reason as to why the results really took that long to come. That's a period of about 8 to 9 from time of collection to the time the results, they're not the results came. Thank you.
So thank you very much, Yeta, for that question. So Lucy, we have a question from Yeta. They want to find out what happened around the time that the client had the 2 high viral loads, and what could have been the circumstances that led to this viral load result not coming on time. So Lucy, would you like to comment on that? Lucy and the team, did we dig deep and find out why the patient had 2 unsuppressed viral loads on TLE and later on went to suppress? What could have been some of the reasons?
we went on to find out that concerning the 2 viral loads, even as we were concerned. So the client at some point, she was staying alone, so adherence was not too good. So sometimes she wasn't taking drugs, sometimes she can take if she remembers. As you can see, she's an old lady. Thereafter, she came for this second viral load, which was 96,263. When we engage her in health adherence, we even involved the grandchildren who were there, who were not staying with her. We asked them to start staying with her. From that time, the adherence has improved, and she's a happy woman now because she has someone to stay with who is reminding her to take medication at the right time with the correct dose.
Okay, thank you very much for that response, Lucy. So, Yeta, I hope we got that response clear. So the client at that point did not have enough social support, so adherence wasn't good. Hence, she had the 2 high viral loads. And after engaging her in EAC, now we can see that she's suppressed, she's adherent to her medication, she's not missing appointments. So maybe get one more comment. Take one more comment from the participants before we can discuss the questions that Lucy and the team have raised.
Okay. So Mary Beck says there's also a need to share such information to our clients during initiation and continuation of treatment so they understand the benefits of CART. Matero says something interesting. They say our pharmacovigilance report at Matero Level 1 hospital shows high incidence of adverse drug reactions in clients over 50 years. Looking at the last viral load, I would recommend that viral load be done to have the latest results. Probably also do resistance tests.
Okay, thank you very much. I would love one of our pharmacists to comment on the adverse drug reactions in the elderly patients. Would you have a comment on that?
I think extremes of age are some of the risk factors for reacting to that. So I think that's consistent with
Okay, so as we have been told by our pharmacists here at the hub, the extremes of age are actually at high risk of adverse drug reactions from ART. So on the last comment, Dr. Mpeta, resistance testing, what's your take?
What about it?
So there's a comment that perhaps we could consider doing resistance testing in this patient. What are your thoughts?
Okay, in this patient, first of all, we have to start with the latest viral load, which is barely a year ago, I think was undetected. So basically this patient was doing very fine. Doing genetic testing, genotyping viral loads below 1,000, I think will result in a failure because the machines that we have cannot read viral loads below 1,000. So that's a reminder to everyone there that if the viral load is less than 1,000, don't even think about sending for genotyping because it will fail and it won't achieve anything. Yeah, but speaking generally over this patient, I don't know if you want me to do the other questions or end.
Yep, okay. We will go to Dr. Mweemba, then we'll allow you to also pass the
right. That's fine.
So I think we'll now go on to the questions that Lucy and the team raised. And the first question was, can they transition this lady to TLD or should we keep her on the same regimen? Dr. Mweemba, would you like to comment on that one?
Okay. So I'll just go through some of the things that when I got a case and then I went through. So she's elderly. That's one thing that we need to take into account. She has a BMI of 29. I think that we need to take into account. She has a normal BP. She has a normal kidney function, about 50. Her cardiovascular risk, when I calculated, if if you assume her cholesterol are normal, is only 4%, and her fracture risk is also very low. The only thing that makes her at risk is the age and that she's female, unless there's some data that we don't have whether she had a fracture before taking alcohol or she was on steroids, but that information has not come up. So my take is that she has an undetectable viral load, and with our guidelines, she can be transitioned to TOD. But because of the age and the sex, I've always think ahead that maybe we can put her at a risk for a fracture. And so when we have tough ED, I think she will be a good candidate for tough ED in the future.
Thank you very much, Dr. Mweemba, for that one. Dr. Mpeta, do you have anything to add?
Just about also the concerns about the BMI. I think it's
28. She's overweight. 28.
The BMI.
Oh, okay. All right.
She's overweight.
All right. Yeah. The second question, which is, or is it on the same? And I think I agree with Dr. Mweemba. Yes, she qualifies to be put on TOD.
Okay. Would you like to comment on the second one? What measures are put in place for the care of the elderly?
I think what measures are or should be in place, I think it's early diagnosis. One thing that we have neglected, I think, in the elderly is early diagnosis. This woman was lost her husband, and I think going by Zambian demographics, we know that having been widowed or divorced is actually increases the risk of HIV. And I think I wish that should have been screened much earlier than 2005, probably. So then the other thing is counseling elderly people about preventive measures with regards to HIV acquisition. So if we can look at from the last time the first husband died to the second, probably if she had knowledge about condom use and now PrEP, I think it's something that we could have prevented this woman from acquiring a new infection. The other thing I think is what Dr. Mweemba talked about, risk of cardiovascular diseases, kidney diseases, malignancies. And I think also we know that she's advancing in age, assessment for dementia, which can actually affect taking of ART. So probably in a patient, I think there was a question of what rate caused the viral load. Probably if we probe further, maybe she was genuinely forgetting. So early dementia and also just dementia in the elderly should also be something that we should be looking for. Yeah.
Thank you very much, Dr. Mpeta. We'll go on quickly to the last question. And as we tackle the last question, I'll just ask Dr. Simenda to kindly get ready to share your slides. So the last question that we had from Lucy and the team was, are there any plans to include them in the national guidelines? Do we have any comments on that? What do you think, Dr. Mweemba, Dr. Mpeta?
I think for me, I think that the guidelines obviously have tackled a number of NCDs, but maybe we need to focus them towards the population that is at risk. And I think that probably we need, just when we meet next time, is we need to emphasize the point of elderly people, and then we need to follow them up better.
So it's time that we eliminate pediatric HIV, then adolescents will become adults who eventually become the elder. But for me, I think one of the real perils of this case is where you literally see her crash her viral load, because I think, as Lucy said, she got support, her granddaughter, to help her. Because one of the things we know with HIV and with aging is neurocognitive deficit. And it's very nice that Mary Begg observed and said, what exactly went into that ESC? Because the ESC that someone like me may need may be something different from a 70-year-old. So this woman literally needs someone to give her pills for her to suppress. So I thought that was very good, because dementia is very real at the age of 70, and it's also common with HIV. So that was a pearl for me. Dr. Simenda, please share your slides.
So as we wait for Dr. Simenda to share the slides, maybe we can get a quick feedback from Lucy. So just to summarize what has been discussed, is your patient eligible for transitioning? Yes, she is. But what would be preferred is when Tafade is available, she's given a regimen that has TAF in it. Of course, we talked about how the bone mineral density is affected more with TDF than TAF. And as we manage the patients, elderly patients living with HIV, we also need to look at the comorbid conditions, and something that has come up in this discussion is the issue of dementia. So they need a lot of social support. They tend to be more forgetful. So that would probably help. We should keep that in mind as we are managing elderly patients living with HIV. And of course, moving forward in our guidelines, probably we could add a bit more information regarding how to manage the elderly living with HIV. So Dr. Simenda, are you ready with your team? Dr. Simenda, you can go ahead with the presentation. So now we have a second case that is from Nakambala Urban Health Center, and it will be presented by Dr. Simenda and the team. So it is also related to the topic we're discussing today, which is HIV in the aging population.
So Dr. Simenda is
muted.
Our mentors. He mentors Nakambala and Mazabuka. But Dr. Mweemba, as they are preparing, one of the things I like about ECHO is that it sort of challenges us, isn't it? Like we're moving with the way the adolescent pediatrics, but actually the elderly are the future. I don't know in practice what you've seen when you see the elderly. Personally, when I talk to the relative, everyone's confused. No one knows this 80-year-old man is on ART, they're frail. I don't know what your experience has been.
I think obviously because I see a lot of kidney disease, and so I see a lot of elderly patients. They need more time, and sometimes when you sit and you're looking after them for more than 30 minutes, sometimes the sisters might not give you that room. So just remember that they need a lot of time because they have all these comorbidities that we just discussed. We've been using efavirenz. Just remember that efavirenz also can worsen that dementia issues, and that's one thing that probably we forgot to mention. So they need more time. They need a lot of time. And you need to explain each tablet like one by one. They bring all the small bag of tablets, and they show you exactly how they are taking, because most times they may not take. And obviously they need more baggings than the general population, because they need someone to help them.
Okay. Thank you very much, Dr. Mweemba. So Dr. Amanda, are you ready to present your case? You can go ahead if you're ready.
Yes, thank you.
Oh, all right, go ahead.
Thank you. And good afternoon to the entire network. We are presenting the case from Nakambala Clinic in Mazabuka district. We have a patient. She's female, 66 years old, and was diagnosed and commenced on combined antiretroviral therapy in 2005. At the time, she had stage 1 disease according to WHO classification. At Nakambala, she joined the clinic in 2017 as a transit from Kanyama Clinic of Lusaka. She is a retired human resource manager, and she got widowed in 2003 when the husband died. She's had 5 deliveries, and currently only 3 children are living. The other 2 died as adults. Her presenting complaints at Nakambala has been easy fatigability, shortness of breath, recurrent coughs, chest congestion, and she experiences recurrent asthmatic attacks, and frequently has the gastrointestinal upsets, pain. She records vomiting, nausea, and frequent dyspepsia. In the past medical history is that apart from being on the antiretroviral therapy from 2005, in 2016, she experienced a left-sided stroke, and this stroke rendered her weak for almost 1 month, 1 year, and within the year she recovered. In 2017, the following year, am I still clear?
Yes, we can get you.
Thank you. In 2017, she developed heart failure, which was diagnosed at St. John's Medical Center with an echo and clinical symptoms. She was then put on anti-failure medications, which she continues today, but were recently changed last week. She is also persistently from 2017 been recording low or to very low blood pressures ranging between 96 and 110 systolic and 60 to 70 as diastolic. In 2003, she also records that whilst in Mazabuka, she was admitted twice at Mazabuka General Hospital for severe asthmatic attacks, and she was treated. That's when she commenced episodic treatments of attacks. But I should add that after clarifications on the weekend, she also records that she tends to be allergic to many allergens like humidity, dust, perfumes, pungent smells, and even some soaps. So she has a wide range of reactions, and these tend to congest the chest and cause some feeling of choking. So from 2017, she has mainly, from the books we reviewed, been taking enalapril at 5 milligrams mostly, Lasix at 40 milligrams, Slow-K, and at one point she was put on atenolol. We also saw evidence that she was given prednisolone regimen from time to time, and she keeps salbutamol and minophyllin, which she uses when she has the chest congestions, being described as a asthmatic like attacks. Last week, on Tuesday, after review, she was put on a new treatment that is Losetam, 25 milligram, spironolactone, 25 milligrams, and she was maintained on Lasix. So on physical examination, she looks 66 years old. She has mild gingival hypertrophy in the mouth. There's some nail changes, especially darkening and a bit of clubbing. The chest shape was normal. Auscultation, we could elicit some fine basal crepitations, especially on both lung fields. The heart sounds were normal, were no murmurs. And for the stomach, there was nothing abnormal detected. She has no edema in the stomach or on the legs, except that plethoric lung. Her BP on examination that day, it was at 142/78. The pulse was at 90. Respiratory rate was normal and temperature normal. Her weight is 61.7 kg and her height is 1.6 meters. We also did and reviewed the investigations done so far. So in the first column, we note the first ART combination was Triamine 30, but the following year, in 2007, it was changed to AZT, lamivudine, and nevirapine. She stayed on this regimen for approximately 12 years until 2017, when she was changed to TLE. Then she records that she reacted to TLE within the 2 weeks and had to go back to the clinic. The reaction, according to her description, was that she had choking and asthmatic like attacks for the 1 week, so she couldn't bear it. She went back to Kanyama and she was put back on the nevirapine-based combination, which she was using until her recent visit to Nakambala this year. So this year, when she was reviewed, it was found that her viral load of 31st July 2018 was high. It was at 2,469 copies. And advanced adherence counseling had been done. And during this time, we repeated the viral load last week on the 24th. We found that it was suppressed at 624. But prior to this, she was actually commenced on AZT, 3TC, and loperamide boosted. That is what she's taking now. The CD4 counts have remained. The highest recorded in 2018 was 453, but generally she's recorded 384 and 374 in 2015. The HB, which we did last week on the 23rd, was at 13.7 grams. The creatinine done on the 23rd of May, again this year, was 109, and the LLT is at 29, and the AST is also at 27. So our questions is, what is the best regimen that can be prescribed to this lady now? And what is the optimal treatment for this heart condition and the low blood pressures and the associated asthmatic attacks or congestion? And could there be, how can we manage the risk of a recurrent stroke, bearing in mind that she had a stroke in 2016? Our presentation ends there.
Thank you, Dr. Smenda, for that presentation. Just to summarize, so we have a 66-year-old female who's been on ART since 2005. And from the history that we've been given, this is a lady who initially was started on what we used to call Trimin 30, which is stavudine, lamivudine, and nevirapine, which she took for 2 years up to 2007. In 2007, the D40, which is stavudine, was replaced with zidovudine. So she had been taking this regimen of AZT3TC with nevirapine up to around February 2017, when she was switched to TLE, tenofovir, lamivudine, and efavirenz. But the patient seemingly reacted to this regimen and was switched back to AZT3TC NVP after 2 weeks. So the challenge that they had is they did not have any viral load results, though they had samples that were collected. That was last year, July. And they only got the first result in 2019. We're not so sure which month. I think Dr. Smenda can confirm. And at that time, the viral load was noted to be high at 2,469 copies per ml. So over a week ago, the patient was switched to AZT3TC with, is it atazanavir, because of the because of the high viral load. And I guess with the history of having reacted to TLE, they were not so sure which nukes to use in this patient. So as we speak, the patient is on AZT3TC and atazanavir, but the repeat viral load that was done on the 24th of May, that was received on the 24th of May, showed that she's actually suppressed at 624 copies per ml. So they have a couple of questions, but before we address the questions, perhaps we can get some comments or questions from the participants regarding the case that has been presented. Do we have any comments? It is complex. So do we have any comments from our participants? From the hub, do we have any questions, any clarifications? For Dr. Smenda, I guess I wanted to find out the switching to AZT3TC, is it atazanavir or lopinavir? Just to clarify on that, it's atazanavir?
Yes.
Okay, thank you very much. So do we have any other comments on the case? So of note, this patient also has other comorbid conditions. She was diagnosed with asthma in 2003, for which she's been receiving intermittent treatment. So she has a lot of allergens. She reacts to a lot of things in the environment. Dr. Smenda gave us the list. And she was also diagnosed with a heart condition in 2017, for which she has been receiving therapy. She had a stroke in 2016, which she recovered after a year. So do we have any questions for Dr. Smenda and the team? Perhaps Dr. Mweemba, is there anything you want to clarify regarding the case? Comments?
What's our functional status? she walking? Is she weak? Is she?
So did you get that, Dr. Smenda? We
Yes,
have a
I
question.
did.
Okay, so you can go ahead and respond to that one.
Right. Thank you. Good afternoon. She is functional, but it's dependent on the medication. Currently, she's being kept by the granddaughter, and she helps with the nursing of the children, but records that frequently she barely makes it. She still has a lot of easy fatigue, and she's dependent on medication to function.
As in the New York Heart classification?
Oh, my internal medicine is gone. Maybe around 3 or 4.
Okay. All right. Thanks, Dr. Smenda. Do we have any other clarification or questions? Okay. So we have a question from the hub. You can go ahead. Material. Okay.
It's okay. Good afternoon. I would like to find out what her initial CD4 count was, because in 2005, if I'm not mistaken, the eligibility criteria was stage 1 and CD4 below 200. I mean stage 3 or 4, and the CD4 count below 200, and Stacey was in stage 1 when she was initiated. And then the other question I had was, for her various allergies, was she given any antihistamines? And among those, were there any of the cardiotoxic ones?
Okay, thank you. So, Dr. Smenda, we have 2 questions. The first one is, at the time she was being initiated on ART. We noticed that WHO clinical staging was stage 1. So did we have a CD4 count then? Because back then we're using a CD4 count as a criteria for initiating ART. And the second question is regarding her allergies. Did she get any antihistamines?
Thank you so much for that question. We had inquired that what happened at the time when she was diagnosed. She said that she just had the constitutional symptoms of fevers and so on. There was no serious opportunistic infection. So we said that it was class 1, because she said she was sort of privileged because she works in the health system. She used to work for Ministry of Health. So she was somehow commenced without, I think, severe disease. And the CD4 count is not recorded for us because she only transferred to Nakambala in 2017. So we only have the CD4 count of 2015, 2018, and now 2019.
Okay,
and
thank
as
you.
for the antihistamines, we didn't find, maybe some Piriton, but we didn't find a consistent use. Only the prednisolone was quite explicit and repeatedly used, the steroid.
Okay, thank you very much for your response, Dr. Smenda. I think we have a question from Material Level 1. Material, can you quickly go ahead with your question?
Thank you very much. Thank you, Dr. Smenda, for that case. We just need to understand the rationale behind substituting NVP with atazanavir. And we now attribute this viral load suppression to enhanced adherence counseling that was successful or to atazanavir. Thank you.
So, Dr. Smenda, you can respond to that, and then we'll get a question from Saidi.
Thank you so
they
much.
Want to know the rationale for the mono switch to a PI.
The PI. At the time she was being reviewed in April, going into May, we didn't have this second viral load. So the staff had assumed she had been actually in treatment failure. So they switched her based on the viral load of 2018, which was more than 2,000.
Thank you. So we quickly get a question from from Saidi, and then a comment from Dr. Thomas before we can address the questions and have get views from the subject matter experts.
Good
Saidi,
afternoon.
go ahead.
Good afternoon.
Good afternoon.
Yeah, I would like to ask the doctor which class of allergy she's been developed, either class 1, class 2, or class 3, and why you couldn't try to change or to reduce the dose either daily basis or the dosage, or just to change either of the medicine, just one or two, rather than just changing the whole medicine, the whole combination.
So, Dr. Tlenda, did you get the question?
I got the question about the classes.
Okay.
I'm sure I'll get help from the hub.
Okay. So they wanted to know whether she was classified in terms of her reaction to the TLA. Was it life-threatening? Was it something that warranted stopping the entire regimen or just doing a single substitution? Was it stage class 1, class 2, class 3, or class 4?
Oh, good afternoon. The classes there were yes.
Okay. Anyways, I guess we'll give you time to probably try and give us the feedback on that. It's something that we probably never looked at. So, Dr. Thomas, quickly with your comments, and then we go to the first.
Good afternoon. I think the single drug substitution from NBP to ATVR, as a nation, we are phasing out the NNRTIs, and the viral load is basically less than 1,000 throughout. I think that should be the reason. That's what I thought.
Okay, so we have a contribution from Dr. Thomas, and regarding the monoswitch from NVP to atazanava, which is that, as you know, we will soon be phasing out NVP. So probably that was a justifiable switch if we look at it in those lines. I'll ask the experts if they have to comment on that as they discuss the first question, which is what is the best ART regimen as at now? So Dr. Mweemba, would you like to comment on that?
All right, so I'll just give my and then I have consulted a lot of other clinicians, so I hope that we can, I'll give those views since they're not here. So she's female, 66, her BMI is 24.1, which is normal. For the age, she has probably some risk for dyslipidemias. This includes atenolol that she's been taking. It includes the steroids that she's been taking. It includes the CKD because her eGFR is about 53 to 55. So that puts her at the high risk for hypercholesterolemia or things like that. She was on D40 for some time as well, and that also puts her at a high risk for dyslipidemias. So she's a risk for dyslipidemias. She already has cardiovascular disease, that is stroke and heart failure. She has other comorbidities that we'll discuss, asthma versus other things. She has a risk for metabolic bone disease, and this includes her age, her gender, her CKD with an eGFR of, again, 53, steroids, and the atazanava that she's currently taking. So for me, she has a high risk for fractures as well. The GI symptoms, I think that maybe most of them actually are coming because of the heart failure, and because of the prednisone that probably she's taking from time to time, because maybe she's not covered on proton pump inhibitors, which we have to be careful as well. The low BPs might be the withdrawal of steroids from time to time, and then maybe she's going into some adrenal insufficiency from time to time. And also the anti-failure medication, that maybe we're giving her a higher dose than necessary, and so we need to think about that. She's on AZT, which might worsen her heart failure issues, and so that needs to be considered in her regimen. So my regimen would be tough ED. So I would give her tough ED because of all the risks that she has, and I don't know whether. I think we need to discuss whether we can arrange her tough ED from our center, because we do have, but I don't know how she can be getting it. But if she can access it, I think that should be the best for her for now. If we can't, then we might have to go to my second COD. Her kidney function is not bad enough, and maybe we can risk the bone issues for for the time being. So that would be my second option, if we can give a TAF ED. I think that the reaction most likely, if she's asthmatic, maybe it was most likely due to efavirenz rather than TDF and 3TC. And so it should be nice to try her on TAF or TDF. So that's my first answer. We'll go to the next question later.
Okay, thank you very much. Dr. Foloshi, do you want to comment on that?
Is like, why talk about TAF? We don't have TAF. But
Yes.
I know as of on June 26th and June 27th, TAF will actually be available in Zambia. So I think that should not be an issue. So both ladies are going on TAF.
TAF ED, okay. All right, thank you very much. So at this, we have discussed for now the best ART regimen, and we have a recommendation, which is TAF ED. We've actually been assured by our pharmacists in the hub that the consignment is actually in. So you will be getting it in your facilities very soon. So we could quickly go to the second question. Her heart condition, congestions, low BPs, how do we address this?
So I think I've discussed the low BPs, that we need to be careful when withdrawing the prednisolone. And secondly, probably we need to, for the medications and failure medication, is that we need to titrate them properly. We need to educate her on her water intake and salt intake and everything, so that we don't have to increase the doses very, very much. But having discussed with the cardiologist, Dr. Kabwe, I sent her the case so that she can just have a look at it. Is that her strong recommendation was that she needs further evaluation, because she wants to decide whether the patient has heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. The echo that we got was a moderate ejection fraction. It was around 41, and she still wanted to do her own echo so that she can decide whether the patient needs a full regimen on anti-failure medications that we are going, because at the moment is that the regimen that we're giving her is not good enough if she was heart failure with reduced ejection fraction. So she wants a further assessment for that particular patient. And so maybe we need to make an arrangement when the patient can come in and we assess her fully. Secondly, the asthma, she has clubbing, and she has also some cracks. Having discussed with Dr. Mateo thought that we really needed to rule out idiopathic pulmonary fibrosis. And again, he also thinks that we need to bring her in for further assessment, because she'll need a CT chest just to rule out that. And probably that's the reason that she's responding to the prednisolone. She's responding to the prednisolone because probably she has idiopathic pulmonary fibrosis, especially that her asthma was only diagnosed after 50 years old. And so that gives it a bit atypical as a true asthmatic. In the meantime, maybe we can still continue giving her the inhalers that she's getting just to relieve her. But I think that the recommendation that she comes in for a full evaluation. AVT is not good for her. I think I've already mentioned that. What was the other question? Yeah.
So basically that the low BPs, the heart condition, and the congestions. So now they just want us to comment on the risk of recurrent stroke. How do we reduce that?
So again, so you can imagine how many consults that I had. And this is the beauty with elderly patients, is that you need to involve everyone. I think that is very important, that you need to call everyone, because sometimes you think that you know it all, but you find that the issues that you get from the consultants is very helpful. So I consulted Dr. Mweemba, who thinks that because she has heart failure and a previous stroke, that's high risk, she needs to be on low-dose aspirin. We discussed the issue about statin, whether we need to start her on a statin. He thinks that the statin should have been given at the time that she had the initial stroke, because it only benefits you for the initial 6 months. But what she needs is a cholesterol measurement. So probably when she comes here, we need to do a cholesterol measurement so that we decide whether she needs the statin. And the statin we're going to use will obviously based on the risk, and we need to think about the interactions with the drug that she's taking.
Thank you very much, Dr. Mweemba, and also Dr. Simenda, for that very interesting case. It has generated a lot of discussion regarding, comorbid conditions that we find in our elderly patients living with HIV. And I think after today, we have an eye-opener, such that as we are seeing these patients in our clinics, we'll be thinking beyond just HIV. What other comorbid conditions could they have? And of course, we already talked about the risk of polypharmacy and drug-drug interactions as you treat the comorbid conditions. So I will just go ahead and summarize the recommendations for this case. The first one, which was regarding the ART, I think we've discussed. This lady will benefit from TAF ED, which we've been assured will be available in your facility soon by the end of June. The other option is to give a TLD. And for the second question, how do we manage her congestions, her heart condition, her asthmatic attacks? We've had input from different specialists, as you've heard from the discussion, including the cardiologist, the pulmonologist, and they would love to, be able to help in evaluating this patient. So the recommendation for her is that she gets the latest echo done. And if we could, we would want to get a CT done because her asthmatic attacks may just be due to what we call pulmonary fibrosis. And since she's been receiving prednisone, that may have been helping to actually relieve her symptoms, and hence that response to treatment. Then for the last question, how can you reduce the risk of stroke? So we've been told that for her, since she also has heart failure, she can benefit from low-dose aspirin, but we'll still have to get a lipid profile and see, of course, if she has a high cholesterol, then we'll probably go ahead and treat. So Dr. Smenda, are the recommendations clear for now? Do you have any last comments, clarifications from what has been discussed regarding the case?
I think they are very, very helpful. So we'll be waiting to hear when we can refer her for the echo because it's not available in Mazabuka, and the cholesterol measurement and the lipid profiles are currently not running, not even in the private hospital around here.
I think one thing that you may want to consider is to check with the patient what's better for her, because I know we have physicians up in Livingstone and at Choma as well. So maybe you can also engage the physicians in Choma. I know there's Dr. Mweenba. I think there's Dr. Mutengo up in Livingstone. I know Livingstone can do echoes. They can do your CT. Then you can have a full conversation if the patient is unable to come all the way down here.
I think so too. That tell us when the patient, if the patient is able to come here, then we can discuss and we can make an arrangement so that maybe she finds me and then I can do the coordination for all the things that are needed, or she goes to Livingstone. So let us know.
Thank you. Yes.
So, yeah, I think we've had two good cases, and I just want to thank the presenters, the case presenters, for the time and effort put in preparing these cases. I think the majority of the network today has benefited from this discussion. I'd also like to thank our didactic presenter and subject matter experts right here in the hub. Thank you all for your contributions. So I guess we'll end the meeting here, and I'll just ask Nomsa to make a few announcements.
Yeah. Next week, we are looking at mortality and loss to follow up. Dr. Mpeta will be doing that. We are appealing to our network to send us any case of a client that has been out of care that we are trying to initiate on therapy. We are looking specifically for a case of that nature. How do we reinitiate ART in people who've been lost to care, and how we go about it? Because we know we get a lot of questions about it.
Thank you for that update, Dr. Foloshi. And Nomsa, do we have any announcements?
Yes, and thank you so much, everyone, for staying on. We also want to apologize. We just overshot a little bit and we've seen a lot of dropouts. But for those of you that have stayed on, thank you so much for staying on. But we also want to encourage the network. If you can and your network is good enough, please switch on your videos, turn on your videos, because this is an interface interaction and we'd like to see you so that we interact, and that's why it's a video conferencing. Unless you have an issue with your internet, then we will take on that. But we would like to encourage as many as you are on the network to keep your videos on. And please, again, from the network, submit your registers as soon as possible. We appreciate those of you that have been submitting, but please do submit your registers. Thank you so much for participating. we look forward to the next session on Monday.
Thank you.